Privilege me to present Dr. Ruchika Mehta. She recently joined Midstream Mediclinic Midstream, bringing with her the wealth and experience and dedication to patient care. Dr. Mehta's journey into medicine began with childhood aspirations, partly inspired by the medical TV drama series ER, where she admired the fast pace and the impact work of doctors. However, it was a personal experience that truly solidified her passion for endocrinology. As a teenager, a family member was diagnosed with diabetes. As Dr. Mehta witnessed firsthand the challenges her family faced, deepening her commitment to medicine and sparkling an enduring interest in the field of endocrinology. Dr. Mehta completed her medical degree at University of Nairobi, followed by extensive training in internal medicine at the University of Witwatersrand. She earned a fellowship of College of Physicians and a master in medicine with a thesis on drug-induced liver injury in patients using anti-tuberculosis and antiviral medication in 2019. He later sub-specialized in endocrinology, completing a fellowship in endocrinology and metabolism at Wits in 2024, with an observership at the University of Federico Hospital in Naples, Italy. So that's really impressive. Dr. Mehta is passionate about addressing the holistic needs of her patients, particularly in the field of endocrinology, where she specializes in managing diabetes, pituitary, thyroid, obesity, osteoporosis, and parathyroid disorders, among other conditions. Her personal connection on diabetes care has driven her approach to patients with empathy, dignity, and professionalism, challenging common misconceptions about the disease. Dr. Mehta's career spans both public and private healthcare. While she has spent much of her career in public healthcare, where she played an important role in training interns and registrars, she is no stranger to the private sector. Originally from Nairobi, she has extensive experience in Kenya's healthcare sector. In addition to her clinical work, Dr. Mehta has contributed to the body of research in medicine, including publications on the prevalence of diabetes and the association with adverse health outcome among patients presenting with COVID-19. Among others, her academic achievements are a testament to her commitment to the advanced knowledge of endocrinology and medicine. So it's really a privilege for us to welcome Dr. Mehta here at Midstream. And today she's going to present the topic of Cushing syndrome beyond the moon phase, because not all weight gain is a lifestyle. Thank you so much.
Thank you for the kind introduction, and good morning, everyone. My apologies for the delay. So today's talk is about Cushing syndrome, something that we're all very aware of. However, sometimes our recognition can be a bit delayed, and so hopefully I would like to inspire earlier recognition of the syndrome. So I'll start by describing a patient. I'd like to start by describing a patient to open the discussion. So this is the patient I have seen before, 14-year-old boy in grade 9, who first presented to medical care with seizures, but over the next 3 years, the patient's mother reported that he had persistent weight gain despite having a normal appetite, and this was associated with low mood, easy bruising with minor trauma. Compared to his siblings, this patient was shorter, and he had no significant change in vision, and there was no sleep apnea, and there was no arthralgias. He was diagnosed with hypertension 5 years previously and started on treatment. And I suppose at this time, that should have been a red flag why a child was being diagnosed with hypertension. However, this was not worked up and he was started on treatment. And he denied any other chronic, topical or oral. And he lived with his family, and there was no significant family history apart from hypertension. And his other siblings were well. So on examination, he was unremarkable except for a tachycardia, and there was no plethora on the face. He had short stature, but there was no, it was not syndromic, and it was symmetrical in nature. There was a moon facies, which we describe as, a deposity on the cheeks area, and there was a dorsocervical fat pad and a supraclavicular fat pad. Of note, one of the characteristics of this syndrome is when you have these violaceous striae that can occur in unusual sites. So in his case, he had violaceous striae in his inner arms and inner thighs and anterior abdominal wall. Of note, the striae in this scenario tend to be more than a centimeter wide, and they tend to have this purplish discoloration because tearing of the collagen exposes the blood vessels underneath, so that's why they appear purple. He also had some truncal obesity, and this is also an important distinction in these patients, whereby the adiposity tends to be around the abdomen and it usually spares the upper and lower limbs. And he had some gynecomastia as well. There was no bruising at the point of examination, and there was no proximal myopathy when he was examined. So this is a picture of his striae. So I'd like to point out how these are occurring in unusual sites, as I mentioned, inner arms, inner thighs, and anterior abdomen, right? And you can see the color of these, and they're quite wide. In his case, they've coalesced to look like how they look currently. So on further examination, he also had sparse axillary hair. He was a Tanner stage 3 and had truncal obesity with no organomegaly, and he had an ejection systolic murmur, but otherwise normal cardiac and respiratory examination. His workup was unremarkable except for the renal functions, which showed an alkalosis. You can see the bicarbonate there is 37 and a hypokalemia of 2.5. This was spontaneous. He was not on any medication that would cause potassium wasting. He did not have any losses reported, right? And the rest of his examination, the investigations were unremarkable at this point. So I'd just like to bring your attention to some of the clinical features that are associated with Cushing syndrome, because that was our working impression. So this is a cartoon which is supposed to depict some of the features. So I'll just go top to bottom. And so emotional disturbances, these patients can have, over a long time, they can have cognitive changes, but they can have initially just the emotional disturbances. If it's a pituitary origin of the tumor, they can have the pituitary can grow within the sella turcica, causing headaches, right? And if this adenoma or tumor expands upward, it can abut on the optic chiasm and cause visual changes, usually a bitemporal hemianopia. The moon phases is one of the characteristics that usually draws attention to these patients. And long-term untreated Cushing syndrome does cause osteoporosis. So these patients usually can present with fragility fractures. The complication of LVH is as a result of long-standing hypertension in these patients. And the buffalo hump used to this is now called a dorsocervical fat pad, as you can see, right? And of note, these features tend to overlap a lot with run-of-the-mill obesity. Like this is not an unusual finding patients who are overweight. And then you can see the obesity is mainly truncal, right? And they do tend to have the skin that becomes thin over time and it bruises easily and does not heal easily, right? We've described the striae over here. And in females, they may present with menstrual irregularities such as amenorrhea. And proximal myopathy is also one of the characteristics of these patients. So some of the complications that can occur then not only include the cardiac disease that we've discussed, we have some LVH and osteoporosis over time with vertebral fractures and also hip fractures. But it can result in infertility in patients, and the visceral obesity comes with its own complications over time, and also they can get atherosclerosis and fatty liver. So that is why it's something that we need to look out for. A lot of these things are reversible if we identify and treat the Cushing syndrome. If we look at the causes of Cushing syndrome, we can divide it into two broad categories: exogenous and endogenous causes. And by far, the commonest causes are exogenous, which is the use of corticosteroids. Now, this can be iatrogenic, and sometimes it's unavoidable because some patients may have a refractory hematological illness, such as immune thrombocytopenia, or a rheumatological condition which necessitates high dose and long-term steroids, in which case it's an unavoidable consequence. However, if a disease-modifying therapy started earlier, we can prevent this. A lot of times, however, we have seen that this is a consequence of patients using over-the-counter medication. Prednisone is actually available from some pharmacies without a script, and we have seen patients just go and get returns and refills for years without any proper indication. It does have a slight euphoric effect. Patients do feel better, so they tend to just continue using it on their own. And that is by far the commonest cause that I have seen in my clinical experience. The gout facts that we see, patients they contain non-steroidals and steroids, and patients use these commonly. Another source of exogenous use is when it's unknown to the patient that they're using it. It can be intraarticular injections, it can be topical. A lot of these face lightening creams we've seen that are used contain high dose steroids. And this is patients who are inadvertently using these medications and giving themselves Cushing syndrome, right? But if we were to look at the endogenous causes, right? Then in that case, the vast majority come from the pituitary, in which case it's called Cushing's disease. So exogenous is the commonest, and then followed by endogenous. And of the endogenous causes, Cushing's disease is the commonest, followed by adrenal causes of the disease. But I'll elaborate more on this now. So of the endogenous causes, then we can divide it into ACTH dependent or ACTH independent, in which case it's either being driven by ACTH or not. So as I mentioned, Cushing's disease then becomes the commonest in this category, accounting for about 80% of cases. And in some cases, ACTH is secreted not by the pituitary, but by a tumor. And usually this tumor can be in the lungs. And in this case, the presentation may be unusual because these patients, instead of gaining weight, they may be losing weight from the underlying malignancy, and then we present with the other symptoms. So this one has a caveat in how they would present. In the ACTH independent causes, it's when the adrenal glands autonomously secrete cortisol. It's independent of the pituitary control. And this can be due to benign adenoma, or it can be due to a carcinoma. And the carcinomas tend to, of course, also present with, they may have the weight loss, right, instead of the weight gain, but they tend to have very rapid symptoms, and they can co-secrete adrenal androgens. So in females, they may present with rapid virilization in a female. So this is when if the patient is co-secreting cortisol, but with another adrenal androgen, we should consider carcinoma rather than an adenoma. However, in this talk, I wanted to focus more on when to investigate these patients and how to investigate them, right? Because as I mentioned, a lot of the clinical features overlap with metabolic syndrome. So you can have the diabetes, hypertension, the adiposity. How do you differentiate? If you started testing every metabolic, our yield will be low. So we need to have a high index of suspicion. So for example, our patient who was having weight gain despite a normal appetite, and he had hypertension at a young age with all central adiposity, that's somebody who should have been tested, right? And sometimes patients will develop multiple progressive features. You're diagnosed with hypertension, within a few months you have diabetes, within a few months you have dyslipidemia. That kind of patient with rapidly progressive features should also be considered to have we should have a high index of suspicion. Also, in any patient who has unexplained features such as hypokalemia, metabolic alkalosis, osteoporosis, we should also then trigger workup for Cushing syndrome. And all patients with adrenal incidentalomas are supposed to be investigated for secretion of adrenal hormones. So if now we've determined who should be tested, I'll just go into this to determine why we use the test that we use. So by nature of cortisol, its secretion follows that of ACTH. So they have a circadian rhythm. As you can see here, there's a natural peak of both these hormones, whereby ACTH peak is followed by a cortisol peak. And this is usually at about between 7 and 9 in the morning. This holds true for most patients. And you can see there's a dip in the afternoon, and then there's another dip later. And then it has a dip at about patient starts to rise. Again in the morning, guidance of testing. At the salivary cortisol, So just before I go to that, when we, as a principle in endocrinology, we always do pledge testing. So if we do calcium, we do it with the parathyroid hormone. If we do the cortisol, we do it with an ACTH. So we like to do pairing of the hormones because one determines the other. And for when we're testing for excess of any hormone, we test it when it's supposed to be at its lowest. So for Cushing's, where we're thinking of excess cortisol, we test for it at its lowest at midnight. Testing for deficiency of a hormone, we test for it at a point where it's supposed to be at its highest. So for example, adrenal insufficiency, we test in the morning when the hormone is supposed to be at its highest. So then that is why we do midnight salivary cortisol, because it's supposed to be at its lowest at night. And we usually do for a patient with a low index of suspicion, such as a patient in whom we are not really thinking about it. It's a metabolic patient. We just want to rule out. One test is sufficient as a rule out. However, in a patient who's got multiple features, unusual features, and you have a high index of suspicion, then we want to do at least 2 different tests because we want to do it as a rule in, right? And when we do the test, we like to do tests across different spectrum so that we increase our diagnostic probability. And we need it to be, the test should be usually more than 1.5 times the upper limit of normal for it to be positive when we're testing saliva, and 3 times the upper limit of normal when we're testing the urinary cortisol. So the salivary cortisol, you usually give the patient a swab and you tell them preferably not to brush their teeth before they're doing the test, so that you don't have any small blood vessels that are you don't have any rupture of the blood vessels, and they shouldn't eat something before the test. Again, we tell the patients to do it at midnight, but we prefer that they don't go to sleep. This doesn't strictly mean midnight. It's usually at the patient's usual bedtime, right? So even if it's at about 10:30 or 11 p.m. at night, that's when their usual bedtime is, and that's when we prefer the test. And not that they go to sleep at 10 p.m. and then put an alarm to wake up at midnight to do the test, because that beats the purpose of it, right? And that is one of the reasons we don't actually do a serum cortisol, because waking them up, pricking them to test them actually will cause a false spike in the cortisol, and the test is then unreliable, right? So when we do the midnight salivary cortisol, we give the patient a swab. They keep it at their bedside, and just before their usual bedtime, they chew on it on each side for a few minutes, soak it with the saliva, and then leave it by the bedside. The advantage with this is we can do it more than once, right? And this specimen is stable at room temperature. They can do 2 different specimens and, take it to the lab the next morning, right? However, then the other test we have is the urinary cortisol. This is done over 24 hours, and as you can imagine, it's a bit inconvenient for the patient, but it has its advantages, which I'll explain in a bit, right? So in this case, we tell the patient if the time of collection is at 8 in the morning, you void your bladder in the toilet at 8 o'clock, and then from 8 a.m. onwards to the next day, 8 a.m., any urine that's produced goes into the bottle. However, we discourage them from peeing directly into the bottle because of the preservative of boric acid that it contains. And then another test that we have available to us is the 1 milligram dexamethasone suppression test, whereby we give the patient a tablet of dexamethasone, the 1 milligram, again, which they take at about bedtime. And then at 8 in the morning, they have to be at the lab to test the cortisol levels. And this follows the principle whereby if you took the dexamethasone at midnight, it's supposed to suppress your ACTH spike, and then it's supposed to suppress that cortisol spike. So when we test it the next morning, it should be less than 50 nanograms per mole. So these are the screening tests and how we choose them. Why will we choose whichever of the screening tests we choose? So the late night serum cortisol, as I mentioned, is fraught with difficulty because normally they say if you really want to test a late night serum cortisol, patient should be admitted 48 hours before so that they adapt to the environment of the hospital. You have to have an indwelling cannula. You're supposed to test it when the patient is asleep. It's very impractical, especially if you have a noisy environment, right? So that is why serum-free cortisol can be measured at midnight, but its utility is actually not great. However, the 24-hour urine cortisol, as inconvenient as it is, it accounts for the diurnal variation that a patient may have because the ACTH and cortisol may be secreted in bursts, So in a patient with if you have an abnormal sleep-wake cycle, this will account for the fact that you don't have a midnight dip of the cortisol. And because it measures the free cortisol, anything that affects the cortisol binding globulin will not affect this test, such as the patient using estrogen containing products like an oral contraceptive, which will affect the cortisol binding globulin. You mitigate that by using just the free cortisol measurement here. And when we do it, we measure the urine volume and the urine creatinine to make sure that it's a good sample, right? And if this test is more than 3 times the upper limit of normal, we consider it a positive test. However, if it's higher than normal but less than 3 times the upper limit, it's considered equivocal, right? And this test is not reliable in somebody who's got chronic kidney disease for obvious reasons, right? And these patients can have a false positive when they take excessive fluid intake. Sometimes the urine output is not adequate according to a patient. So they want to falsely increase the urine output and they may drink a lot of water, but then that can actually give you a false positive result. And then I mentioned the late night salivary cortisol. Again, it's to assess the abnormal circadian rhythm because the diurnal variation is usually lost in these patients. In somebody who has Cushing syndrome, you don't have the usual midnight dip that occurs. So that is why it's at midnight you will have a higher than normal salivary cortisol. And it also measures the free cortisol that you find in the saliva. So it doesn't, it's not affected by the cortisol binding globulin variation. So it is easy for patient to do. They can do it in their home environment, do 2 or 3 samples two nights in a row, and then bring it to the lab. And then, yes, this test, however, cannot be used for somebody who's got an erratic sleep-wake cycle or night shift workers, doctors, nurses, anyone who works in that kind of environment, they cannot do this, and a 24-hour urine will be better for them. Then the low-dose dexamethasone suppression test can be done. Either you give them a 1 milligram tablet at night and test the cortisol at 8 in the morning the next day, whereby you're expecting a normal response will be for suppression of the cortisol to less than 50 nanomoles per ml. However, we can do a 2 milligram 2-day test, whereby you cumulatively give them 4 milligrams, such that you give them 0.5 milligrams every 4 hours for 2 days. So, for example, you can do 6 a.m., 2 p.m., 6 p.m., 2 a.m., like that for 2 days, 0.5 milligram each time, and you'll end up giving them a total of 4 milligrams. And then again, after 2 to 6 hours, so if the last dose at 2 a.m., again at 8 in the morning, you do the cortisol and it should be suppressed. It's considered to have better specificity and higher sensitivity than the overnight 1 milligram test. So the caveats to this, however, we're giving dexamethasone so that it suppresses your endogenous ACTH by negative feedback. But somebody you may be concomitantly using a drug, which is a hepatic enzyme inducer that is metabolizing the dexamethasone. So it doesn't achieve the desired level and it doesn't suppress your ACTH. So then you will have a false positive because your cortisol will not be suppressed in this patient. Or if the patient is having diarrhea, malabsorption, they don't absorb the dexamethasone will not do its job of suppressing the ACTH, and again, the cortisol will not be suppressed. So in some cases, we mitigate that by actually measuring the dexamethasone values, levels, and to see if the patient reached adequate levels. And in a patient, again, with elevated cortisol binding globulin, for example, due to pregnancy or hepatitis, because this measures total cortisol, again, it may be elevated and you can have a false positive. And similarly, somebody may actually be taking the correct dose of the dexamethasone, absorb it, and not have a drug metabolizer inside too, but they may have a glucocorticoid receptor polymorphism, which means that, again, the dexamethasone effect of the patient is variable and you can have a false positive or false negative result. And this one will be difficult to actually determine. So that is why we do tests across different platforms. And a patient with a big tumor may also have a false negative because they fail to suppress because it's just the tumor size and the cortisol burden that they have. So Again, just to bring it to summary, the test that we have, we usually do one test in a patient with a low index of suspicion and at least two in a patient with a high index of suspicion and try to do various tests. So in our patient, the young boy that I showed you, his 24-hour urine cortisol, his volume of the urine was 900 mils, and that was the cortisol value. This is corrected to a daily urinary cortisol measurement, and it was 2,849. So this was well above the 3 times of upper limit of normal. And on a different platform, a salivary cortisol was also more than 3 times the upper limit of normal. And his ACTH was within normal. So as I'll show you now, negative feedback from the cortisol should have suppressed the ACTH. And this was not the case. So you have a detectable ACTH. So this is considered positive. It's an inappropriately normal value, and this is considered an ACTH dependent, right, cortisol secretion. So basically now we've gone from what are the clinical features to when to suspect Cushing's, and if we're suspecting it, what are the tests that are available to us? And here we have now diagnosed the Cushing syndrome. So then what is the next step? So just to go through this algorithm, so we have a clinical suspicion, and the history will be the differentiator between exogenous and endogenous. If we have a history that suggests the patient is using medication that has caused the Cushing's, our workup ends there, and then our management part starts. But in this case, if the patient is not using exogenous and we think it's endogenous Cushing syndrome, we do the screening test. If it's negative, it's unlikely. But however, if it's in high probability, we do the screening tests, and when the screening tests are abnormal, then we have diagnosed Cushing syndrome, like in the boy that I showed you. Then what is the next step? We determine now, after you diagnose the Cushing syndrome, you want to determine whether or not it is ACTH dependent or independent, as it determines whether it's pituitary or adrenal in origin, right? If the ACTH is normal, like in our patient, or high, then it's considered ACTH-dependent Cushing syndrome, also known as Cushing's disease. Whereas if the ACTH is low or suppressed, then it's autonomous secretion from the adrenal gland, and then we need to image the adrenal glands, right? And then, so once we image the adrenals or the pituitary, you're looking for a tumor that's producing the hormone. So when it comes to the pituitary gland, it can get a little tricky because usually these are microadenomas, right? If it's a tumor that's more than a centimeter, it's easier to diagnose. But when it's in this equivocal range of less than between 6 and 9 millimeters, then it gets complicated, and we may need to consider further testing with an inferior petrosal sinus sampling. At this point, I hope the patient has been referred to endocrine, because then further tests are needed over here, right? In which case we need to do further stimulation test or a petrosal sinus. Of course, if it's an adrenal etiology, we image the adrenal glands. It's usually unilateral adrenal adenoma, and then the management is straightforward from there. You can have a unilateral adrenalectomy. So what are the management principles? So we've diagnosed the patient who has ACTH dependent or independent, image the patient appropriately, and now the next step is, I'll just very briefly do the management principles, right? And I'll start with exogenous Cushing syndrome, whereby this is a guide to when we need to taper steroids. Prolonged high-dose steroid use suppresses the HPA axis, the hypothalamic pituitary adrenal axis. So what happens is, after we've used high-dose steroids for more than 3 weeks, the adrenal axis is suppressed, which means that once you stop the steroids abruptly, the axis hasn't recovered and the adrenal gland does not resume cortisol production. This can be fine for a patient who's on their day-to-day feeling well, but once the patient goes into any sort of illness or crisis situation, they can present with adrenal insufficiency. I once managed a patient who had been using gout packs for many, many, many years, came with, developed Cushing's, went undiagnosed, was well, stopped all his medication for 2 years, was admitted to the hospital with cholecystitis and went to theater, and on table he had adrenal crisis. And this is true after all his medication. So for 2 years, when it comes to his ordinary life, But the moment he was put through surgical stress, he went into refractory shock. And there was a high index of suspicion, so somebody did the tests and he responded well to steroids. And that tells us that your axis can remain suppressed for a long time. So this guides us when to taper steroids. If you use anything more than 5 milligrams, 5 milligrams is considered the physiologic equivalent. If you use anything more than 5 milligrams for anything more than 3 weeks, then you fall in this category where you need to taper. If you can test probe the HPA axis, the hypothalamic pituitary adrenal axis, and you use doses between 5 and 20 milligrams for more than 3 weeks, you can probe the axis, and if the axis is intact such that you do a synlactin, the patient produces adequate cortisol, you can stop the steroids without a taper. However, it's usually these tests are not always available, so it's better to assume axis suppression and taper. Anything more than 3 weeks with a dose more than 20 milligrams, it has to be tapered to allow the axis to recover slowly. And this is a guide to how sometimes we taper. It can take months, it can take years. As you can see in somebody who used 60 milligrams, which is not an uncommon dose in ITP patients or hematological conditions, the taper has taken 42 weeks. That's close to a year. And in the higher doses, we can first taper, usually 10 milligrams a week. But when it comes to once we reach 35 milligrams, the taper can be at 5 milligrams a week. And you can see once we reach 20 milligrams, the taper is even more slow. We now need to taper at 1 milligram at the lower doses. But unfortunately, we don't have 1 milligram tablets for prednisone. So at this point, usually once we reach the 5 milligrams in our setting, we then have to convert ideally to hydrocortisone, the Cobocort tablets, because 1 milligram of prednisone is about 5 milligrams of hydrocortisone. So at this point, we can then use hydrocortisone to allow a slower taper. But please note that the adrenal axis suppression can be a very, very long time, and a slow taper is what's best. And what if the patient with Cushing's disease, i.e. a pituitary tumor? The first line of management in these patients is transphenoidal surgery, usually relatively safe, well tolerated. However, 20% of patients after what looks like apparently good surgery may have residual disease. And 15 patients of those with initially successful surgery may have remission later. Recurrence later. So up to a third of these patients after surgery will need additional treatment. And one of those patients who are not surgical candidates, from the get-go, some patients may need medical therapy, either because they declined surgery may not be available, they may not be good surgical candidates due to high risk, due to some of their comorbidities. And in that case, the medical management has a role, right? But otherwise, first line in Cushing's disease is surgical management. And the therapeutic goals in Cushing's disease is to remove the tumor, the adenoma, while maintaining normal pituitary function, right? And to restore normal cortisol secretion over time and to reverse the comorbidities. But in a lot of these patients, after the tumor is removed, the urine cortisol may normalize, but the comorbidities may not reverse. And some of them may not reverse. But it does still reduce overall mortality once we remove the source of the cortisol production. And if we use medical therapy, it can be in patients who are going to go for surgery but need acute management of the hypercortisolemia, for patients who have failed previous surgery, for patients who are poor surgical candidates, or in somebody who now is awaiting radiotherapy as a last line, and now you're just bridging them with medical management. So the principle of medical management is guided by this. This is the cholesterol synthesis pathway. This is the pathway for the production of aldosterone, cortisol, testosterone, right? So basically, these are the different enzymes that are involved in the pathway, and antagonizing these enzymes is what the drugs do. So you can see this is just the 11 beta hydroxylase is the enzyme that's important in the final step of conversion of 11-deoxycortisol to cortisol. And these are the various drugs that act at this point. That's mitaropon, that's mitotane. Mitotane is usually, because it's adrenalytic and it causes necrosis of the entire adrenal gland, it's used usually in the carcinomas, not usually for the Cushing syndrome from adrenal adenomas. Then this is etomidate. Etomidate is available as intravenous, so it can be used in the pre-op scenario where you're using it as an anesthetic drug, and that's ketoconazole. And this drug has subsequently been named solodrostat. So as you can see, then, sorry. Yeah. So I just wanted to move this. Yeah. So that you can see when we're using the drugs, either they're working at the level of the pituitary gland. So these are the dopamine agonists, such as cabergoline, also known as dostinex, or the somatostatin analogs, such as pasireotide. These are working at the pituitary level, right? These may not be available. Somatostatin analogs are quite expensive. They may not be available, in which case, then instead of working at the pituitary level, you can work straight at the adrenal level where you're targeting the cortisol itself. So as I mentioned, this ketoconazole, mitaropon, and also solodrostat that's available to work at the adrenal level by that reduction. Alternatively, you will by targeting the glucocorticoid so that ACTH production may continue, cortisol production may continue, but you're just targeting the receptor at the tissue level to prevent the action of the cortisol. However, this does not stop production of ACTH or cortisol. And in the case of Cushing's disease, the tumor may actually continue to grow and cause what we call Nelson syndrome. So this is another representation of the different drugs that are available. So these that work at the pituitary level are pasireotide, cabergoline, and temozolomide. Temozolomide is usually for pituitary carcinomas. These are all drugs under development. And drugs that work at the adrenal level include the imidazoles such as ketoconazole and levoketoconazole. There's mitaropon and mitotane. Mitotane, as I mentioned, is usually for adrenocortical carcinomas. And at the tissue level, you have mifepristone. Relacorilant is available in Europe and America, not in South Africa at the moment. These are the management options in somebody. The commonest cause of endogenous, as I mentioned, is Cushing's disease. So the options that are available to us is ideally transsphenoidal surgery. But for somebody who fails surgery, what are the options? You can have secondary transsphenoidal surgery. So you go back in and reset whatever is left. Alternatively, you can give them radiation. If you're giving them radiation or even surgery, you may need to bridge them with medication, right? Or medication can be used as an alternative to either of those options. And as salvage, you can actually do a bilateral adrenalectomy so that you will eventually render the patient adrenally insufficient, but replace those hormones for life. So that's just an overview of Cushing's, how to test, when to suspect, and how to manage it in a very brief form.
Thank you so much. It's really quite a nice detailed presentation. As a male, of course, I look at my own belly. Say, am I having Cushing? I'm going to inspect myself.
Low index, please only do one test.
Thank you so much. Yeah. So the questions, and I think probably it is as the saliva, obviously, testing during, obviously, I mean, you mentioned very well that for the midnight one, somebody need to be asleep and has some kind of a needle, and that means the nurse should come quietly, enjoy the blood. And how practical is that?
So that's why we don't do the serum cortisol, right? And so that's why we encourage salivary cortisol. So I tell patients, it's your bedtime, keep the swab next to your bed. You're just about to fall asleep. Then put it in your mouth on both sides, chew on it for a few minutes, put it back in the container and go to bed, right? Okay. And you can do that 2 nights in a row and then bring the specimen to the lab. That is why we don't do the serum cortisol, because we don't want you to be pricked. It causes pain and then it causes a cortisol spike.
Yeah. And one of the big things from the patients out there is always concerned about the moon phase. And we know that cortisol plays a critical role in inflammation treatment. we see that with the connective tissue disease, we see that in the fibrotic lung disease, special dose that are reversible. And we always have to use high dose of cortisone, about 60 milligrams sometimes, 1 milligram per kg, 5 for 3 months, and sometimes use as much as this improvement. The question is, for some patients, actually, you could withdraw. I normally like to drop from 60 to 10 milligrams. How practical is it actually to taper slowly? Can I drop from 60 to 10 milligrams without causing any harm? Or do I need to go like 1.55 or 10-10? What are the evidence?
This is a guide as to dropping from 60. When we're at 60, we can drop at 10 milligrams initially for a few weeks. But once we get to the smaller doses, our taper has to be smaller. As I mentioned, you can be well and fine if there's no illness, right? But if you come into any sort of crisis, it can be a flu. It can be minor surgery like a dental extraction, right? And that can send you into a renal crisis. And at that point, then you will have hypoglycemia, hypotension, hyponatremia, and this can become life-threatening. Now, if somebody does not think of replacing your steroids at that point, it can become life-threatening. So that is why we do a very slow taper, and somebody at 60 milligrams, they should be mentally prepared. It can take up to a year for your taper to be done successfully. Because even what happens is they get a lot of glucocorticoid withdrawal syndrome because the glucocorticoids are making them feel better. There's the euphoria, there's energy. Of course, comes with increased appetite. When you withdraw that, they tend to crash even with the energy levels.
And what is the sensitive marker to see adrenal insufficiency obvious when you stop your cortisone? Is it blood pressure or glucose?
So
we've been taught that if you got most of the patient with the insufficiency will develop hypertension, and most of them actually don't.
So the blood pressure is not primarily regulated by cortisol. So we would look at the blood pressure because it has a permissive effect on the adrenaline and noradrenaline, right? But in addition to that, we look at the glucose. Again, glucose is not primarily regulated by cortisol, it's by insulin, glucagon, right? But also the electrolytes, the sodium and potassium. If you have a hyponatremia, hyperkalemia, then we know that we're looking at an insufficiency.
Any other questions?
Yeah, I have one comment and
Coffee, guys, please.
And I go.
Yeah.
So just regarding ACTH, we can see from the algorithm that it depends a lot on your actual value, actually how you work up the patient. Now it's a very labile molecule, so it breaks down very quickly. So the lab needs to make very sure it's taken, it's put on ice, it reaches the lab very quickly, spun down, done immediately. So just to consider that it's difficult if you have a far-flung site and it comes in over 2 or 3 hours. It might be breaking down, you might be in the normal range, and you would have a totally different workup then. So just from the lab side, we are very diligent to make sure that they actually get the right value.
And 10 of the results, how long does it take? A week, a month?
No, it's a random access, usually in all the big labs. So as soon as it hits the lab, the result is out within an hour. So it's not a long procedure. And then I have one question. Some patients are quite difficult to work up. These screening tests are not all 100% sensitive or 100% specific. So especially in patients with severe depression or alcoholics, they can have this pseudo Cushing's and have some false screening tests. So what tests would you recommend for those patients?
So the pseudo Cushing's, as you mentioned, the alcoholics, obese, even pregnancy and depression, right? In those patients, we still sometimes we do the same screening test. But remember, when we reach that point of ACTH, it will be suppressed, and if we do any imaging, the imaging will be negative in these patients, right? So usually also the history will guide us. And if you know that the patient has severe depression, severe alcohol abuse, they should be in the earlier part whereby you're using have a low index of suspicion in screening these patients. So ideally, they should not have that heavy kind of workup.
I just want to ask, is hydrocortisone available? I'm looking at this tapering.
Yes.
Available now.
So it was out of stock up until a few months ago, right? I believe Covacort is now back. I'm not 100% sure. I've not prescribed in the last few days or weeks, but usually hydrocortisone is available as Covocort. Yeah.
Thank you for the presentation. Just for clarity, so there's no role for a random cortisol in Cushing's disease and Cushing syndrome, but in adrenal insufficiency, one could do a random cortisol.
So in adrenal insufficiency, again, you want to do it at its peak, right? So that will be here at 8 in the morning, right? Doing a random cortisol, even in a patient with adrenal insufficiency, if you look at that table, right? If you do it here at midday, it will be low, but that doesn't mean they have adrenal insufficiency. Do it here when they're expected to be high.
So in a patient who comes in with hypertension and I'm waking him up hypotension, and one of my clinical suspicion, because I'm not thinking it's actually going is adrenal insufficiency, can I do it then?
No, do it in the
Not wait
morning.
for 8 o'clock.
No, do it in the morning. Do it in the morning. Even for, I mean, it's off topic, but even tests like testosterone, right? We tell patients, if meals can actually reduce your testosterone value. So, yeah. So
Okay.
do it.
What meals?
No, testing, just testing. Yeah, so just do it in the morning fasting.
We need to go into a history of the patient's sleep cycle because obviously circadian rhythm will be affected by it. Like if you get a healthcare professional who comes to you with hypertension and you want to do it at 8 o'clock, would that be valuable?
So you should still have so your sleep-wake cycle in adrenal insufficiency, I would still, in that case, sometimes it's off, right? If you have a night on, then don't test them in the morning, then test them at night before they shift. Because by the 7th night, you have a circadian rhythm whereby you're awake at night. So on the night of the 7th night, when the shift starts, that's when the cortisol should be peaking, right? But if you're not sure, do it on the 7 nights off, do it in the morning. Yeah, but it can get tricky. That is where the free cortisol or 24-hour cortisol comes in for some patients.
What if I'm 5 minutes late? What if I did it 8:05? 10
No,
minutes
it's
late?
fine. It can be a strict because not everybody is a wake up and go in at 6 in the morning. Some people's natural cortisol will be 8 in the morning. So that's why I tell patients between 7 and 9. It doesn't have to be strictly 8 a.m. There has to be range. Again, these are population studies that determine 8 a.m. Someone's could be 7, someone's could be 9, but it's giving you a better indicator than doing it at noon.
What about time in the lab? Do 8 o'clock, arrive at 12 o'clock to midday. Any changes? Is the neutrophil, all these cells, the play any roles eating up the glucose, whatever
The
it
salt
is?
is taken at 8 o'clock.
Yeah.
And it reaches a little bit later.
Yeah.
It's not such a labile molecule, so it can tolerate
Okay.
transit time.
So how many hours? Doesn't matter.
Well, any sample coming in more than 4 hours, we would be wary because there is a chance of hemolysis and sample one.
Hemolysis wouldn't release cortisol though, would it?
No, not that one. And I must say with the chemiluminescent methods that we use, it does not interfere as much, but if it's 4+ immunized, we will have a problem.
So in our way, to exclude pseudo-Cushing, the patient that we suspected Cushing disease, we do a decimal present stimulation test. And thinking that, the ACTH is not too much thing